Hello everyone, this is Dr. Mohid and today we will be discussing about parasitic skin infections. Alright, and I guess in the OPD, right, this is the most common topic we would see. One of the main highlighting topic already maybe which is coming in your mind is scabies. Yes, scabies, the different type of scabies which are there. It is quite prevalent across everywhere in the world, because first of all, this usually happens at a very crowded place, right? Yes, so maybe somebody who is living in a very crowded place or low socioeconomic status people, or maybe who is not having a very good personal hygiene, or maybe due to contacting multiple people, this could happen, right? And the main problem about this is, if somebody in the family of 5 is having this parasitic infection, right, in the skin, what happens is, even after we treat them, yes, so maybe the other person is not treated, yes, so that is the reason the risk of reinfection is very high. Yes, so in the treatment part we will be discussing that if we treat one patient, so we have to undergo something called as an umbrella treatment. Yes, so if one person is undergoing the treatment, yes, so make sure like the people who are in contact with that one person are also treated. Otherwise our treatment plan would fail. Why? Just because he could get reinfected. Yes, and probably even if we have not done even the counseling right, so there are questions raised on us. Yes, that okay, fine, you must have told me this and that and everything. So we have to be very crystal clear with our patients in the OPD. Yes. Alright, fine. So let us just start with the discussion about parasitic skin infections. The first of all, I am just taking up with scabies. Alright. This, as you can see on the screen, we have this individual, yes, who is causing it. What is the name of this one? So definitely a lot of us might know the name already. This is Sarcoptes 𝗲𝗵𝗵. All right, this is the one who is causing all the mayhem. It creates something called as burrows in the skin. Yes, what layer of the skin does it breaches? We'll be reading that as well. All right. And what are the different types of scabies? It is not just like just one type of scabie. It just happens in the between the digits. It's not like that. There are different types and this and that. We will see everything one by one. So the organism who's causing this infection is Sarcoptes 𝗲𝗵𝗵. Okay, and one of the main thing is that it is highly contagious. Yes, so it becomes more serious that if the person is living in a overcrowded area. Yes, so that is the reason, like if one person is infected, so everybody around it would be infected, and it would be like an endless vicious cycle that somebody is itching in the room all the time. Yes, okay, so overcrowded areas. Okay, so it could also happen by sharing personal belongings, could be towels, handkerchief, or any other, right, which could transmit the mites. Yes, so it is very essential that we should keep in mind, whenever we are using anything of somebody else, so we should be very particular about it. Probably could be the nail clippers, it could be comb, and could be anything. Yes, so now we know, right, what is the reason of this spread, and anybody could have it. It is not like somebody who's having it is not like anybody could have it. It is not like somebody who is like very upscale people, they wouldn't have this. They could have it as well. So it is very important to just maintain our own hygiene, so that we are not affected with it. All right, pets are also one reason. We could transfer it to them and they could be continuously transferring it to us again and again. So if somebody has it, it's important that in the umbrella treatment, everybody who is in the room should have a complete treatment of it as well, right? And the main thing is that it is very easy. The treatment is very easy. We just apply it once and it is all done. Okay. Oh, and the next thing about it is something called as, it is a watershed disease. All right. Why is it like, if the person is having mites, okay, that is the mites are causing them itching. Alright, but what's happening is it is only in the upper surface of the epidermis, right? Yes, the first layer which is affected is stratum corneum, and then it makes its way down of the epidermis. Alright, so while bathing, right, what happens is our skin layer, it is being shed off. Yes, we are scrubbing it off. Yes, so the person after having a bath, yes, the mites are being taken off. So that is the reason the symptoms are reduced. So that is what it means about this point, that is, it is a watershed disease. Watershed, or you can also say this as it is a water wash disease. Alright, two things can be said. Okay, and that is all about the introduction part about this. Yes, so over here next we'll be reading about the life cycle, about the organism. But first let me just we just see the images first. Okay, so this is the Sarcoptes scabiei, and this is very important to even identify them. Okay, alright, and over here we can see that the guy is making his way below. Alright, in the lower areas of the epidermis. Okay, over here you can see that something called as burrows. Yes, we discussed already about this burrows, right? So this is the one who is causing it. Okay, and we can see all these linear lines. Yes, we can see all these. Yes, over here we can see as well. Okay, that is one thing about it. And over here we can see this is the hair follicle over here, and we have this Sarcoptes scabiei mite which is here. Okay, and it got infected. Yes, and it is just making its way in the epidermis. It is not going below that. Okay, it is not going below that. So the only thing which can they do is, they can cause pruritus. Okay, alright, and these things, they are the feces of these mites. Okay, alright, fine. We go on to the life cycle about it. So females are comparatively bigger in size as compared to males. Females are larger in size. Okay, and it breaches the stratum. What? It breaches the most top layer of the skin. Okay, which is the most top layer of the skin, that is the stratum corneum. Yes, big smart guys love coffee, so coffee is the one, right? It is the stratum corneum. Okay, till which layer does it breach? It is this is 𝗲𝗵𝗵𝗵𝗺. Okay, so the stratum basale plus stratum spinosum is 𝗲𝗵𝗵𝗵𝗺. Okay, alright, and it takes about 3 to 4 weeks to hatch. Yes, and one of the very key point is when the starting of the infection till the time we have the symptoms. Yes, this would be about 3 to 4 weeks. Yes, to get the next generation of the parasite. Okay, the reinfection, if somebody who is already having the disease, yes, somebody who is already infected with it, yes, and he just got the treatment, and per se he did not take the treatment properly, as he did not follow the proper guidelines of the doctor, what's going to happen is within 2 days he will just start showing the symptoms. Alright, within 2 days the person will start showing the symptoms. Okay, so that is one thing you have to be very careful about. Over here you can see these are the microscopic images of the Sarcoptes scabiei, and these are the feces, and these are the eggs which is continuously being laying, and it lays about 3 to 8 eggs in a day. Yes, and the cycle is vicious. It keeps on going and going and going and going. Alright, over here you can also see the eggs, the mites, and the feces and everything. Okay, alright, clinical presentation. One of the because of this one point, the patient will come to us. What is this? That he is not able to sleep at night. Why? It's not like he's getting bad dreams. It is because of the pruritus. Yes, the nocturnal pruritus is the point that is the reason patient would come to us, that doctor, do something about it. I'm not able to sleep, and I'm having itching all over certain places. We'll discuss about the places as well. So nocturnal pruritus. That is one thing. Okay, we have to be very careful about nocturnal pruritus. Okay, and what do we see in it? Yes, what do we see in it? This is the point. Yes, burrows are being seen. Yes, burrows will be seen, as you can see over here as well, and this is the image we discussed already. Yes, burrows will be seen. It could be linear or it could be different shape, like, you know. Where do we see it? We see in the finger webs. Yes, wrist, cubital fossas. We see it, and something we'll be reading about. Yeah, right here. Next topic, the circle of Hebra. Yes, this is where the most features are. The circle of Hebra, we will be reading about it. Yes, so how does it start? It starts from the finger web and it goes straight up to the genitalia. Alright, and why should we know this? Is because this is the area where we will look for the mites. Okay, scrotum and soles of the infant. Alright, and one of the very interesting point over here is that in the circle of Hebra, the face is not involved. Okay, now we'll discuss why. The face is not involved. Yes, in adults. Okay, in adults we're talking about. Why? Because on the face, right, what happens is we have a lot of sebaceous gland. Yes, definitely the oily skin is helping here. Yes, we have a lot of sebaceous gland, and over here, that is the reason the mites are not able to infect the adults on the face. Elsewhere they are able to do it. Okay, this one point is a bit conceptual. Yes, everything it is just about, we should know it. Yes, it is just like theory part. Okay, this is a bit of concept here, and because of the sebaceous gland they are not able to infect. So it's pretty interesting, right? Because of this one point, the clinical correlation changes, of this parasite and the findings we see. So no face in the adults. Okay, please make sure I'm talking about the adults. Yes, as we go down, there are two types of scabies: the adult scabies and the infantile scabies. Okay, so this point only goes for the adults. Okay, so I guess I can say one more thing over here, that in infantile scabies we will have the adult, we will have presentation in the face as well, right? Because they don't have quite developed sebaceous gland, so they can affect the face as well in the infants. Okay, coming on to the next one, yeah, the symptoms. Where can we find the symptoms? This circle of Hebra answers that question. Okay, so what are these? They are the circle connecting the main sites. Okay, what is it? First of all, as we discussed, yes, so it is the finger webs. Okay, just see, like, it is from the finger webs. Okay, then what? We'll have the wrist, and then we'll have the elbows, then the axilla. Yes, and then it would make its way up to the genitals. Okay, so this is the circle we will follow. Okay, over here we have the finger webs, and we have wrist. Yes, and we have elbow flexures. Yes, anterior axillary folds. Yes, over here, and then it goes on to the nipple and areola area, umbilicus, and at the end we have the genitals. And on the genitals, you see, when it reaches the genitals, yes, what happens is the presentation changes. I just want to give you this thought right now, that over the presentation over here and here are different. Okay, we read in if we see the patients when they are infected on the fingernails, yes, in the finger webs, yes, we could see the burrows and everything, and in the genitals, yes, we could see burrows, but over here we will see something called as nodular scabies. Yes, now what are nodular scabies is, let us just discuss this point over here, that it is not because the nodules are not because of the mites. Yes, as absurd as they sound, the nodules are not because of the mite. The nodules are a reaction of the body towards the mites. Yes, what is it? It is a hypersensitivity reaction that the body is trying to contain it right there. Okay, and then we'll find the nodules. Yes, so it is not because of the mite. It is a reaction of the body to protect us. okay, and the presentation changes while it reaches here, okay. How would we diagnose it? Yes, diagnosis is very simple. Yes, we would just look up for the finding, we will look up for the mite. Yes, what can we do? We can prepare a KOH mount and we can see under the microscope and we can just elicit the eggs, the mite as well, okay. Under the wood lamp, yes, what we can do is we can apply any fluorescent paste. Over here we are using tetracycline paste and we can observe the burrows more clearly. Not usually done, but yes, we can do it. Usually we don't even do these things. We just like, okay, fine, we see the burrows, this, that, we have the history, we start the treatment, okay, as simple as this. Now this is the point I was talking about, the adult scabies and the infantile scabies, okay. The presentation should be very clear in our head that, okay, fine, what is the clear demarcation line? Adults, the palms, the face not involved, okay, and in the children, in the infants, these two will be involved, the palms, soles and the face, okay. Okay, so in the adult scabies we see, right, the face, palms and soles, they are not involved. Okay, and over here in the infantile scabies we see, right, over here these areas would be involved. Okay, fine. And in the adult one, yes, in adult one we have the papules, right? Yes, what are these papules? These are the hypersensitivity reactions. Okay, and in the children we will see papules and the vesicles will also be seen. Okay, now let us just see the presentation in the infantile scabies. Okay, you see like the whole trunk is involved. You see it is quite expensive. You see the vesicles are there, the crusting is there. Yes, you see these hands of these little angels. He is so much affected by this parasite. Yes, he or she. You see. Okay, so this one point, this is one of a very classical feature, okay, about the infantile scabies that we cannot afford to forget. Alright, that is one thing. And so how would you treat it? Yes, we discuss about the whole diagnosis and this and that and everything. How do you treat it? The treatment is very simple if the consultation is very clear to the patient, okay. 5% permethylene, yes, it is go by the name permeth. 5% permethylene we give. Alright, and how does it work? Is it blocks the sodium gated channel. Yes, and that is the reason it blocks the thing in the first place. Yes, sodium gated channel. And the next one is we give oral ivermectin. Okay, and how the mechanism of action about the ivermectin is that it inhibits the 𝗲𝗵. It inhibits 𝗲𝗵. Okay, how is it working is when it inhibits the 𝗲𝗵, so it is not, it has nothing to do with the eggs. It does not kill the egg. Okay, how it kills is that when there is formation of the adult mites, yes, it attacks the adult mite. Okay, it does not kill the egg but the adult mite. Alright, so if somebody is taking this, so we can the mites which are there on the body, yes, that will be taken care about. If we do this, then the next generation of these folks which will come into play and just disrupt our whole treatment, we are taking care of that as well. Yes, so somebody is like the current symptoms and the symptoms which are going to happen, the reinfection part, yes, these both are being treated here. So 5% permethylene and oral ivermectin. So I hope now you understand what are the mechanisms behind these two drugs. Okay, all right. But the thing over here is that it is not recommended for less than 15 age and pregnant or lactating women. Okay, these are quite potent. Okay, so we don't use it in this bracket. Okay, so what we would do is we would just go for topical sulfur. Yes, sulfur is also proven to be very effective, but the thing is it doesn't have a very pleasing odor, so that is the reason patients are not really comfortable using it. But yes, this is the treatment of choice. Okay, topical sulfur. Also in infants who are less than 2 months, we can use it, is absolutely fine, the topical sulfur. Okay, the next one over here is benzyl benzoate. Okay, so this is a very economical option. Yes, it's not much expensive. A benzyl benzoate can also be used. It is a liquid and it just need to be applied on the whole body. Yes, this is the umbrella treatment we were talking about. Yes, that the family members who are in contact, family members, or it could be friends who are living in hostels, XYZ, whatever it is, the people who are in contact, they have to be treated as well. Okay, so the family members has to be treated as well. Fine. One more thing that has to be taken care about, yes, so because one point about the personal hygiene, yes, that the clothes, the linen, the bed sheet, everything which is in contact of that person, that should go under a very extensive hot laundry wash. Yes, so everything should be cleaned up very properly. Okay, and if somebody who cannot do this, is what they can do is they can just take up everything, what all the clothes and the towels and all of it which was infected, it should be just kept in a plastic bag and just tie it up, kept it aside for 72 hours. Okay, all right, that is one way to cure it, to control it. Okay, so this is the point I just mentioned, that clothing, everything which is in contact need to be disinfected, hot laundry needs to be done, or keep in a closed plastic bag. Okay, keep in a closed plastic bag for 72 hours and we'll be done. Yes, nothing to worry about. Okay, so with this we complete one part of the parasitic infection. Yes, that is just the scabies, and now we'll be seeing about the different types of it. Okay, all right. Over here we have something called as a nodular scabies. Okay, this is one we discussed when the circle of Hebra, we completed the circle of Hebra, right from the finger webs, wrist, elbow flexures, yes, axilla, nipple, groin area, yes, and the genitals. So genitals till it reaches there, as you can see over here. Do you see burrows in the scrotal area? Do you see the burrows? No burrows. Yes, they were there. They were there, but the body has infected. The body has reacted to it, and now there are nodules being formed over here. You can see over here as well. There are no, but definitely you can, if you find it, if you see this patient, you can elicit burrows as well, but we are talking about nodules right now. This is nodular scabies. Okay, over here you see in this patient. If you don't know this one point, will you be able to diagnose scabies? No, it's impossible, right? Yeah, definitely the nocturnal pruritus, this and that, you will write permeth, yes, and you will write ivermectin, but you should know what are you looking at. Yes, this is nodular scabies, I know it. Yes, you see over here, yeah, okay, you see the nodules, groin area. All right, fine. Okay, so if we're done with that, the nodular scabies part is done. So the next one is the most interesting one. Yes, this is the third part of the scabies. This is the Norwegian scabies. Norwegian scabies. Okay, this is a very interesting one. Personally, it is quite interesting. When I read about it, I was like, wow. Yes. Okay, this is quite good. So The main reason I told you that why does it happen, why does the patient come to you, is because of the nocturnal pruritus part. Yes, but over here there is no pruritus, the patient is comfortable, but yet there are millions of mites in it. On the patient body there are millions of mites. But why? Why at one spot I am telling you that there is nocturnal pruritus, the patient is running towards you, he is not able to sleep, doctor, do something about it. And on the other side I am telling you that there is no itching, the patient is well and good, is off, is sleeping well, but on the other side I am telling that there are millions of mites. So why there is no itching? To answer this question, we have to understand the presentation. That in that patient, yes, he is so severely immunocompromised that his body is not able to react to it. Yes, the body has just given up on him. Okay, he is immunocompromised. That could be one point. Yes, the other point, it could be that there is loss of sensation in the patient. Yes, the sensation is obviously the nerves are the one, right, who give us a sensation. For example, the hand is affected, for example, the web, and there is no sensation in the hand. So how will the patient tell you that, okay, fine, doctor, I am having itching, do something about it? No, right? And maybe, for example, the patient is bedridden. Yes, he has paralysis, the patient is bedridden, okay, and the people are not taking good care about the patient. Yes, and bed sores, yes, there is one thing, but the patient can undergo something called as Norwegian scabies. Yes, if the patient is not, the bathing is not done well, the care is not taken well, definitely we can see this. Yes, what it can happen is on the back, right, on the back of the patient, we can see something called as hyperkeratosis. Yes, we'll see the image, we'll see the image right now. Yes, as you can see, right, on just this extensive crusting on the back, you see, and the patient will be comfortable. Right here you see. Okay, so I hope I have given the introduction well, and now we can talk about all the points that why there is no itching. Okay, fine. The patient could be immunocompromised, that is the first point. Okay, yes, the next point we discuss was it is loss of neuropathy. Loss of neuropathy. Alright, the third one we just discussed, right, it could be that the patient has paralysis. Okay, so that is the reason there is loss of sensation in that particular part. Alright. Okay, and as we just discussed, right, there are millions and millions of mites, but the patient doesn't have any itch. Yes, so millions of mites in the epidermis, that is one thing we discussed, and there are hyperkeratotic crust on the body. Because of the mites, it is just making a mayhem, and the stratum corneum and in the layers below, right, so we have this crust like appearance. You see these fissures. Yes, you see these fissures on this patient, you see these fissures, on this patient as well. You just imagine if you just take a QH mount and you just prepare a slide and you put it on the microscope, you will see like so many mites, like, yeah, okay. The next type of scabies, that I just wanted you to know for a fact. Yes, nothing a lot of examination point of view things, right? So it's called as scabies incognito. So incognito word, where did we read this? Incognito. I'm not talking about your browser settings of incognito setting, not about that, right? We are talking about tinea incognito, right? In tinea incognito, what was it? Do you remember the etiology why this name was coined? Yes, tinea incognito was something if a patient was diagnosed for tinea, but the treatment was not correct. Yes, the quack, he didn't diagnose it. Maybe he diagnosed it, but he didn't knew, like, okay, fine, what is it? And he's like, okay, fine, just apply the steroid cream and everything is okay. But this one thought lead to development of this new spectrum of disease, that is tinea incognito. Yes, that the treatment was not correct. Okay, tinea incognito. And because of that, what happens is, when you see the lesions in the patient, if you can remember that we had an image of a person's leg. Yes, it was not very aggressive looking, it was hyperpigmented lesions we could see. Yes, that, and once the treatment is withdrawn, the symptoms, they flare up. Yes, that is what about tinea incognito we read. Okay, scabies incognito is the same. Alright, just the same as tinea incognito, we have this scabies incognito. Okay, alright, what is the treatment? We just discussed that we have to give permethylene shampoo or the lotion, or we have to apply on the whole body. Yes, and if this treatment is not done, the patient is just using steroid creams, this will elicit, that is scabies incognito. Okay, alright, so that is all about just the scabies part. Okay, the next is pediculosis, that is lice. Okay, lice treatment. Yes, so I am very sure maybe you might have seen it, probably in the schools. Yes, during the school days, or I don't know when somebody, we have come across this infestation one time in the life. Maybe we saw somebody who has it, or maybe a lot of you had it. Yes, and alright, that is pediculosis or lice, we call it in a layman language, that is lice. Okay, first of all, I just want you to know the classification of it. Okay, so we made this a very differentiating table. As you can see, we'll go by each of the points and the treatment and why it is causing, and everything we'll discuss. So this is the format that I will be following. Okay, alright, pediculosis humanis, capitis. Okay, that is the name of our first individual. Okay, the next one is pediculosis humanis corporis. Does it ring a bell? Yes or no? I hope it does. Okay, and we have this 𝗲𝗵𝗵𝗵𝗺. Okay, corporis and capitis. I hope you guys, we just finished the fungal infection, right? Before the viral one, we just finished the fungal infection, and over there we read about tinea, and in tinea we had tinea capitis, tinea corporis. Where was tinea capitis? What were the main manifestations you could see? In the head, right? So it's the same, that pediculosis humanis capitis. So the more the infection, the predominance will be on the scalp, on the head. Corporis on the body. Yes, tinea corporis, when did we use this word? Was when the tinea happens at the non-defined areas. Okay, tinea unguum, tinea capitis, these are the defined areas. Okay, this is the non-defined areas, that is when we use the word corporis. The same vocabulary, the same concept, everything same, the organism is different. Okay, we have lice, that is pediculosis. Okay, fine, and over here we have this 𝗲𝗵𝗵𝗵𝗺. Okay, so now let us just see one by one. I'll be stating about their manifestation, and then we'll go about the treatment, and then we'll go one by one about these as well. Okay, it does infect the scalp. Okay, it is also called as a head louse, and the patient would be itching all the time. This is one thing, like if you have seen some students back in the day. Now the treatment aspect is very common. You just search it up on the internet and everything shows up. Yes, about this. But earlier, like, people are scratching. This scratching thing, probably even the school teachers, they will call the parents and they just make them aware that this student maybe, he needs to be checked. Probably he should go to a doctor or anything, that he is continuously itching. Yes, this itching thing is the one that this is the reason the patient would come find you. This scalp itching. Okay, and there is a new terminology over here, that is nittis. What is this? These are the eggs of the pediculosis. Eggs are called as nittis. Where do you see the eggs? On the scalp? No. On the hair we'll see, on the hair shaft we'll see it. Okay. But main thing we have to be very careful about is seborrheic dermatitis. Why? Because they have the same presentation. Yes, in seborrheic dermatitis, the flaky skin, the flakes which would be there, right, they would just be on the hair, okay, and even in the nidus is also on the hair. But the thing is, the eggs, the nidus, they are very adherent to the hair, they won't fall off easily. Whereas the seborrheic dermatitis, if it is happening on the hair, yes, it could be easily it is flicked off. Okay, that is one differentiation between these two things. Okay, the nidus, that is the eggs. Okay, all right, these are the one which are adherent to the hairs. Okay, that one point is done. Now let us just go on, see the images. On the left side, you can see this Pediculosis Leishmaniasis. Okay, and we see he just had a very good dinner. This guy is living his life. He had a very good dinner. Yes, just sucked on some nice fresh blood. Okay, all right, and we should be able to identify them, as because it is very important in microbiology, right? Not in derma, it is very important in microbiology to identify the organisms. Yes, and I know it is important for the MCQ perspective, but like, yes, being a doctor, we should we should know these things, even though probably clinically, it may not have this significance. Okay, fine, this is that, but still, we should know about it. And if you see this, if you see these two images, right, this is from my dispensary. Yes, over here, these images I have taken it from the view box. If you see, the patient came to us for a hair consultation. Yes, the patient came to us for a hair consultation. Then this is a female patient came, and she told us that she is having, the density of hair is reduced. Okay, that was the complaint of the patient. Okay, fine. I and my dad were there, and the whole history taking was done. And then we just, when giving the examination of the patient, right, while looking at the hair densities, that okay, fine, you have some hairy, some patches are there, thinning is there, everything is there. While giving a hair consultation, we find out that the patient was infested. As you can see, these images, yes, you see this guy, the Pediculosis Leishmaniasis, is just having a good time right there. And one more image as well. Okay, all right. So this is common. It is not like it is not common. It is not. It's not like it is some rare disease, rare thing to be infested on. Somebody who is very well maintained, they also are affected by this. Okay, all right. So before starting the hair treatment, before starting that with everything, we had to disinfect the patient first. Okay, we had to give her proper treatment, and then we go on with the complaint that she came us about, right, about the hair loss. Okay, so that is one thing I wanted to share with you. Over here you can see, because of the color of the color of the hair of this person, right, it is blonde color, so we can elicit the nits very clearly. You see these black dots, they are the nits. Okay, the eggs which are there, and they are very firmly adhered to the hair. Okay, so we're done with one part of it. And how would we go about the treatment aspect is, we would give 1% permethrin shampoo, very well enough. 1% permethrin shampoo applied, and they are all a part of history, done. Yes, very easy to use. Apply the shampoo, keep it for 5 minutes, and then just wash it off. That's it. And it is recommended, even though it is not necessary that we should give the whole proper umbrella treatment, but it is better that everybody who is in contact, they can apply it, and it is all done. Even in one unit, probably 2 to 3 people can use it. Okay, all right. We use ivermectin, antihistamine, and antibiotics as well to kill the lice. Okay, all right, that is one thing. Antihistamine, just for the pruritus part, we have to give them. Okay, all right. Over here we have the next one, that is Pediculosis Leishmaniasis. Okay, this is also called as 𝗲𝗵 disease. 𝗲𝗵 disease. Okay, I'm not talking about Vegapunk. in one piece we have 𝗲𝗵, Dr. 𝗲𝗵. I'm not talking about that. I'm talking, this is 𝗲𝗵 disease. Okay, all right, and I hope you guys like One Piece. I love it. This is one of my very famous anime series that I watch. I hope I have the release frequently. All right, so coming back to our topic, 𝗲𝗵 disease. Okay, why does it say why the name is very different than the whole presentation? Is because this disease is seen in the people who are homeless. Why this seen is because, as you can see, if I zoom it in, this person, do you think he is living his best life, or he has some very good luxury of a house, of good food, clean clothes? Do you think the patient has it? No, right? These people, they just keep wearing the same clothes again and again and again, and they keep adding layers. For example, they are living in cold city or anything, they keep adding layers and layers and layers, and in between the layers of the clothes there are these lice. Yes, okay, all right, between this layer of the clothes there is this. So what do you think the treatment would be? Yes, to give these people a fresh pair of clothes, right? To have proper hygiene with the clothes. Definitely we'll give the shampoo and this and that and everything, but the cause are the clothes. Okay, all right, that is one thing. So it is in the homeless, neglected person, and excoriating papules would be seen on the body. Okay, all right, fine. And the lice, where is the lice? Where do you find the lice? The lice is on the clothes. Okay, fine. And the person undergoes a lot of itching. Yes, the person itching is because of what? Itching is because of the salivary antigen. The saliva acts as an antigen and body responds to it as an itch. Okay, so it is the saliva of the Pediculosis humanis. All right, that is the one who is stimulating the pruritus part, the saliva, okay, of this organism. All right, so the lice is on the clothes and not on the hair or anywhere else. Yes, I'm pretty sure, but we would find the lice on the hair as well, but just as far as the topic is concerned, we are limiting our discussion. We can see in this person, right? So yes, as far as the topic is concerned, yes, the lice would be on the clothes, not on the body. Okay, right here. How would you do it? How would you treat this patient? Is we would act on the primary thing, that is the clothes part. Yes, the clothes has to be very clear. We have to. There is so much we can do for these patients. Yes, apart from the medicine aspect, right? We can help them. We can financially help them. Probably we can help them get a job, or just try to help them in any certain way. Because these are usually the people who have lost their hope in life. Yes, so anything we could do for them, it is okay. Probably we can get them some lunch or dinner, right? Or anything that we can do for them, even if we give them our clothes is also fine. Yes, all right, so that is about that, the 𝗲𝗵 disease. And the vector, yes, the lice, the vector, right? So it is a vector for the 3 diseases, right? That is a relapsing fever, trench fever, and epidemic typhus. This is a very important point from ESM, right? What is the pediculosis which is there? It is vector for what diseases? This is relapsing fever, trench fever, and epidemic typhus. Okay, this point is important as well. Okay, how about the last one that we have is 𝗖𝗵𝗵𝗵. Okay, definitely we have it on the pubic hair. Is the one which is infected over here. Yes, what are the sites? The common types is we'll find it on pubic hair, we'll find it on the eyelash and axilla. All right, but a very key point, very key concept in this is that we will never find it on the scalp. You just see, I'm talking about scalp, the hair, lice, capital. There is like a new segment, that the capitis thing, but this is not on the capitis. Why? This organism, I'll answer the why part. I'll just write the note first, that it is not seen on the scalp. Yes, why? Is because it does not like to grow on the hairs that are very dense. On the head, right, the density of the hair is a lot, so it does not like to grow there. It likes to grow where the density is very sparse. For example, on the eyelashes, yes, on the pubic hair. Okay, all right. This is so not on the scalp is the point. Okay, fine. And over here in this patient, we'll see something. These blue colored striae, these blue striae, you know, the colored macules which are there. Why do we see? I'll just explain you the concept right here. That why do we see this blue striae is because of this organism, because of this mite, right? What is happening is there is extravasation of blood. Because of the extravasation of blood, we can see this blue striae on the dermis. Okay, all right. We can see this blue striae on the dermis. Yes, that is the reason, because the blood was oozing out. Yes, and it got, and that is the reason we have this paper. So we see these blue colored macules. Okay, why do we see it? Because of this extravasation of blood. Okay, that is the point, and we call this as macula circulae. So what do we call them? Is maculae cerulae. So what do we call this? Is maculae cerulae. All right, this is what we call, and I hope I'm making the pronunciation right. Okay, fine. All right. This point is very important. That is, it is because of what? It is because of the extravasation of blood. Okay. All right. And how do we go about the treatment aspect? Is treatment is the same? Yes. We would just continue giving this. We would ask them to use this permethrin 1% shampoo. Yes, and we would give them antihistamines for the itching part as well. All right. That is all about the pediculosis one. Now let us just discuss about the next part, that is the leishmaniasis. Okay, leishmaniasis, 𝗲𝗵𝗵𝗵, right? This word is a very popular one. Yes, because of the PSM topic, right? We read extensively about this, and the complications are the most important one over here, right? First of all, what do we see here is what are the different types of leishmaniasis which are there. These are cutaneous leishmaniasis, yes, and we have mucocutaneous leishmaniasis, and we have visceral. Okay, all right. So skin manifestation, yes, no other manifestation, and mucocutaneous one, we'll discuss everything once again. I just want to give you a brief overview about the whole thing. Skin manifestation, mucocutaneous, the mucosa is involved, and in the visceral one, the body is involved. Yes, we have the systemic manifestation in it. Okay, all right. And the most important thing is the complication. Okay, and over here the complication, that is the post 𝗲𝗵𝗵𝗵 leishmaniasis. We'll be discussing about that as well. Okay, in a while. Okay, so in cutaneous one, we have the old world and new world cutaneous leishmaniasis. But the thing is how we should be how we can differentiate between these two. All right, fine. Let us just start with the cutaneous leishmaniasis. Okay, this is the old one we will be talking about first, and then we will be talking about the new one. Okay, transmission. Yes, transmission is by what? Yes, is by sandfly. Okay, that is phlebotomous. Yes, phlebotomous. So we read about phlebotomy, right? Phlebotomy, which was this treatment about? Where did we read about the phlebotomy treatment? Yes, tell me. When we were discussing about something about Porphyria cutanea tarda, yes, the treatment was this phlebotomy. Yes, this is phlebotomous. I am talking about the phlebotomy part. Okay, fine. That is one thing we discussed about earlier. Yes, in the rapid revision we did that. Yes, old world. This is an old world, and the names are very peculiar. That is the Baghdad boil, Oriental sore, or Delhi boil, right? Okay, all right, that is one thing. How will be the lesions in this? The lesions are like very, how will be the lesions? Lesions are very characteristic. Okay, we cannot go wrong in the lesion. Okay, fine. These are the nodules. First there will be nodule, yes, then it will go into plaque formation and it ulcerates and then the crust is formed. Okay, ulcerate and the crust is formed, but the very peculiar sign is the sign which we see over here, that when we remove the crust, when we take off the crust, we see something called as a volcano sign. This word is important. Okay, we see volcano sign, and this word is very peculiar for this disease, this infection, that is Leishmaniasis. Okay, we is removed, we see the volcano sign. Okay, all right. And then what do we have? We have these apple jelly nodules we see right in the lupus vulgaris. We discussed this point as well. Okay, all right. So one key point we just discussed in right up in the straight up, because we are reading the cutaneous one version, right? Cutaneous leishmaniasis. We are not reading about the visceral or mucocutaneous one, so there will be no systemic symptoms, only cutaneous symptoms. Okay, so no systemic. Let us change the word over here. We put manifestation. Okay, no systemic manifestation would be there. Okay, now let us go see the images. You see over here. Okay, we see, do you see the crust? Yes, the crust is formed in the patient right here, we see. Okay, and see over here we have this central crusting is there. Okay, central crusting, yes, peripheral scaling, yes. So this is now, I guess, because we discussed so many of this presentation, right? At the end of this topic, I mentioned 3 points that is very important related to this central scaling crusting, because one word change, the answer would change. Yes. So what are the differentials we should have in our head when we see this crusting scaling thing? We'll discuss about that. We just focus on the image right now. Okay, right here you see. Yes. So this is a very new erythematous. The periphery erythema we see right over here. We have some pus as well, but in the later stages it will become like this. Okay, and we remove it, we see the volcano sign. Okay, all right. How about the diagnosis part and the investigation part? Yes, investigation. What do? Is we would take out a biopsy, right? And in the biopsy, these findings are very peculiar. Yes, that is these LD bodies which are there. Yes, LD bodies. Leishman-Donovan bodies. Yes, LD bodies which are there, they are the very peculiar ones in the investigation part. Okay, we are done with the old one, old world cutaneous leishmaniasis. Okay, now we'll read about the new world cutaneous leishmaniasis. Yes, new world. All right, fine. Welcome to the new world. What do we call this? It's 𝗖𝗵 ulcer. I'm talking about 𝗖𝗵 ulcer. I'm not talking about the chick sign. Okay, 𝗖𝗵 ulcer or gum tree appearance. Yes, we see over here, and you see the ear. The presentation is very characteristic. That is, we have the ear cartilage involvement. Okay, we have the ear cartilage involvement, as you can see in this image, right? So this is a new world or old world? This is a new world, right? New world. Only one thing we have to remember, that the presentation is in the on the ear. Okay, fine. Now we go on to the next one, that is a mucocutaneous leishmaniasis. Okay, so we just come to our classification. So we done with this part, we done with this, we done with this. Now we're going with this and this. Okay, so now we'll talk about the mucocutaneous one. Mucocutaneous leishmaniasis. So what is the key demarcating fact point that we just read is the involvement of the mucosa. All right, mucosa is involved in this one. Okay, so what do we see? Destruction of the nasopharynx is a very key classical point. Okay, destruction of the nasopharynx. Okay, Alright, so we just see this images first. You see, just because of this one organism, that's Leishman-Donovan, right? Because of this one thing, yes, the vector sandfly, you just see, right, the amount of damage that it has done. Yes, it just corroded. Is like just it was just never there. You see, so serious manifestation. Yes, Leishman-Brazilinsky is the one who's causing it. Okay, all right, the mucocutaneous one. Okay, fine. Now we go on to the discussion. It is a destruction of the nasopharynx lesions at the face and nose. This word is very popular. We have to know this one word, that is the aspendia. Okay, the presentation is called as aspendia. Okay, all right, fine. And where do you see this? Yes, we see in mucocutaneous leishmaniasis. Okay, all right. Leishmaniasis braziliensis is the one who's causing it. Okay, all right. Now the point that I was discussing you about, right? The central clearing, crusting, scarring. You know what to answer when. Okay, so this is like a revision for you, me as well. Yes, so whenever you see central clearing, peripheral scaling, only one answer should come in your mind. That is, I hope you are answering tinea, because that is the one. Okay, how about central crusting? Where do you see the central crusting, peripheral scaling? Crust is formed in our topic, right? That is leishmaniasis. Okay, how about central scarring? Yes, we read in lupus vulgaris. Okay, all right, that is one thing. Fine. We done with the mucocutaneous leishmaniasis. Now we'll go about the visceral one. Okay, visceral one will have the systemic involvement. Yes, okay. Systemic involvement is there. It's also called as reticuloendothelial involvement. Okay, as you can see, we have the splenomegaly is there. Okay, the bone involvement is there. The bone marrow is involved as well. Okay, and the patient is having extremely high fever. These are the presentation of this patient. We'll be discussing about that. Just look on the images. Yes, you see these small, hypopigmented patches we see. Okay, hypopigmented patches will be the next thing we cover in our lecture as well. The hypopigmented patches. Okay. All right. So this is the one I just mentioned, that high fever, splenomegaly, and leukopenia. The bone marrow is also involved. Okay. All right. And on the site of bite, yes, we see these nodules. These are the cutaneous nodules. Yes, we just saw in the image. Yes, and also we see these hypopigmented patches in it. Okay, all right. And one more thing over here that I should have mentioned it right up over here. That is the leishmaniasis. That is the 𝗲𝗲𝗴𝗵. Yes. So why do we say this 𝗲𝗲𝗴𝗵? Is because kala means black. Yes, it is a word. In Hindi, right? We say kala is black. Okay, and azar is fever. All right, but where does black come from? Where did this black come from? Yes, because after the infection, right, as a complication, there is this hyperpigmented patches we see in the patient. Okay, because of the melanin deposits. Yes, we have this kala, that is the hyperpigmented patches that we see. That is the kala part, and the azar part is the fever part, because the fever is very extravagant in this patient. Okay, all right. Okay, we go on to the visceral one, visceral leishmaniasis. Okay, high fever, splenomegaly, leukopenia is the one we just discussed about, and on the site of bite we have this cutaneous nodules. You see, yes, we have these nodules which we can see over here. All right, and the darkening of skin, that is the melanin deposits, we just discussed that also. Complications is the one I'm banging my head on since the very beginning of this chapter, right? The complications is very important. Yes, what is it? This is the one, I think whenever we read it, right, so this is the first topic we read in the leishmaniasis topic, that is the PKLD. This is why we know about this, right, that okay fine, this is the complication, post-𝗲𝗲𝗃 leishmaniasis. Okay, when does it happen? It happens almost after 1 to 2 years after the manifestation of it. Okay, most common skin manifestation is this. Okay, over here it develops 1 to 2 years after the recovery from visceral leishmaniasis. Okay, fine. How is the manifestation? These are the hypopigmented patches that we see, okay, in the upper limb. Alright, these are the hyperpigmented patches we see. And okay, one question to you, that is what should be the differential diagnosis that we should have in our head when we see the hyperpigmented patches? Okay, alright, I'll be talking more on this one point. Yes, let us just leave this one right here. Let us just leave this one and we'll come back to it. Okay, I hope if you have the answer in your head, good enough. Good, you are doing good job. You have well read about the previous topic as well, right? Okay, this one point we discussed in our rapid revision session as well, the point which I am going to discuss now. Let us just go, we'll come back to that. But first we'll see about the investigation. Okay, what are the investigations that we can do is, we can go about the 𝗲𝗵 staining. Okay, we can go about the 𝗲𝗵 staining, and what do we find here is these are the LD bodies, right? We find here the Leishman-Donovan bodies we find in the 𝗲𝗵 staining. Okay, and what do we see? We also see this 𝗖𝗵_𝗶 form of parasite is also being seen. Okay, alright, what is the culture media? The culture media is very important over here. Yes, a lot of culture media we read about, right? So this is one of it, is the NNN, that is the Novo-Macconkie-Nicoll media. Yes, that is the one we will be using to culture them. Okay, now we are done with the investigation part, right? So we'll just continue the point we skipped on, that is the hypopigmented patch. Okay, how to differentiate between these patches? Okay, the reason I want to go a little bit off topic with this and include more things over here is because of this one instance that I had. Okay, let me tell you that what was the instance. Okay, so one evening, me and my dad, we had a patient. Okay, and there was this couple, a very young couple. Okay, they come to us, and the husband was talking on behalf of her, and he told us that she has these patches on her leg. Okay, and she wants to get a consultation with my dad. Okay, and fine. Okay, and when we saw it, when we saw the patch, okay, we had this diagnosis, differential diagnosis in our head, right? It could be Pediculosis versicolor. Okay, but when we did our physical examination, right, over there, for example, this is the patch. Okay, this is the patched area, and this is the normal skin. Okay, my father, he was checking the sensation. Okay, he told like, do you feel any sensation here? She said, no, there is no sensation. And the normal skin, there is sensation. Over here, do you see sensation? No sensation. In other patches, we see there is sensation, no sensation. Normal skin sensation is normal. And then he asked me that, Dr. Mohit, what do you think is the diagnosis? I told him, this could be Hansen's disease. And he's like, yes, this is the case of Hansen's disease. And in his 26-27 years of practice, this was the second leprosy patient he saw. And the patient was quite comfortable. He didn't knew the intensity of this, right? But we have very good treatment options for this. And then we ask her that, okay, fine, tell me more about the condition. And then they opened up. Initially, when we asked them, right, they didn't give us very proper history, right? They were like, okay, fine, no, this is the only, and it is happening from some time. But when we asked them that any treatment is going on, they were reluctant initially to talk about it. But later on, we asked them, okay, fine, tell us, and then they showed us a receipt that years ago, yes, they were being treated from a very rural area, yes. And that patient they showed us, and this was a case of relapse. She was not taking her medications properly. Yes, and we saw it, and we had to restart the medication again. Okay, all right. That was one instance. Okay, so that is the day, that is the time I thought, like, something which is as easy as this hyperpigmented patch, in derma. And this goes for all the subjects as well. When we see something, we should have the differentials, and we should, be very clear with this. And that day was like, an eye-opener for me, that wow, we read about so much topics, so many details, and when we see in our clinical practice, it is so good. And today I'm very lucky, I feel lucky enough, that I can talk on this, at one point, that is the hyperpigmented patch. And that is the reason I took out this section, and I want to, make this thing clear once and for all the viewers, for lifetime, that when you see hyperpigmented patch, there can only be 3 conditions. Okay, and I have framed them all in a clinical case. Yes, with the presentation, I'll be going on with it one by one. Let us begin. First one, a patient comes to you who has a prolonged fever and comes from the endemic area, who has a scratch sign which is positive, and the sensations are normal. What do you think it is? Yes? What do you think this is? Sensations are normal. Okay, what could it be? Yes, this is the topic, right? We are learning about. This is the post 𝗲𝗵 dermal leishmaniasis. Okay, that is the one we are talking about. Second one, the reduced sensation in the hyperpigmented patch. Okay, we are only talking about that patch. All right, hyperpigmented patches is there, and the loss of temperature. Loss of temperature is the first manifestation which is lost in the sensory part, not the touch. The touch is there, but the temperature is lost, is the first sensation which is gone. Okay, which is this one? This is the Hansen's disease, right? The whole case and everything was about this one. Okay, that is the Hansen's disease. Okay, how about the next one? This is, in a patient we see central clearing plus the scratch sign is positive. Okay, the patient is asymptomatic and there is peripheral scaling. What do you think? What do you think it is? So I hope I don't have to revise the scratch sign. Okay, let me do it. What is this scratch sign? Also called as 𝗲𝗵 sign. Okay, in this, on the lesions, if we ask patient to scratch, the lesions become more prominent. Okay, in like difference between before and after is a lot. Yes, that is a scratch sign. Okay, it is positive in this patient, also positive in PKLD. Central clearing, scratch sign positive, asymptomatic, peripheral scaling. Tell me, what is it? That is the pityriasis versicolor. Okay, all right. Okay, so that is all about the hyperpigmented patch I wanted to go about. Okay, I did went a bit extensive on this, but yes, definitely worth the time. Okay, all right. How about the treatment? Treatment is very interesting. Yes, how about the treatment? In cutaneous, the skin manifestation, right? So we will give oral miltefosine. Very easy, just oral miltefosine will give. Okay, how about the visceral one? Yes, the visceral one is the one which is having the systemic manifestations also, right? Okay. Visceral leishmaniasis, we will give something called as liposomal amphotericin B. Okay, liposomal amphotericin. Okay, all right. We can also give oral miltefosine and the amphotericin B. What is the difference between these two? The normal amphotericin B and the liposomal amphotericin B, we will be discussing this as well. Little bit pharma, but yes, definitely worth the time. In PKLD, what we will give? We will give oral miltefosine and liposomal amphotericin B we would give. Okay. Now let me just come to this point. What is the difference between these two? Okay, the liposomal one and the normal amphotericin B is, We will talk about the conventional one first. Okay, what is happening over here is this drug is extremely nephrotoxic. Okay, if it is nephrotoxic, will you be able to give high doses? No, but the presentation is so severe, right, in the patient. We want to give high doses, but the patient, we want to give high doses, right, but the patient cannot tolerate. So what to do? If we give high doses, it is nephrotoxic, the patient cannot tolerate it. Yes, even though it is cheaper. Yes, then the drug was formulated again. It was packed inside the vesicles, alright, and this was very effective. Even though it is expensive, it is less nephrotoxic, and because it is less nephrotoxic, yes, we could give higher doses. It is expensive, but it can treat the patient very well. Okay, so that is the difference over here. That is what is written over here. It goes by the name ambisome. Okay, it goes by the name ambisome, and it is encapsulated inside the lipid vesicles. Okay, all right. Okay, all right. This is less nephrotoxic, so higher doses can be given, and it is little bit expensive, so it is okay, no problem. Conventional amphotericin B, this is nephrotoxic. Okay. Okay, and because of this, there are a lot of infusion related reactions which are seen in this patient. Okay, and higher doses cannot be given, lower doses has to be given, and it is cheaper. So one thing about this. Okay, so we are done with the leishmaniasis part. Okay, so now we'll go on to the cutaneous larva migrans. Okay, all right. So the whole leishmaniasis topic is then completed. Cutaneous larva migrans. Yes, it is caused by whom? 𝗖𝗵𝗵𝗵𝗵 brasiliensis. Okay, that is the causative organism for this. Cat, dog, or tapeworm. Yes, that is the one which is there. Okay, and in this, the very key point is it moves about 2 centimeter per day. Okay, it would just slowly crawl on the skin, right? Okay, and as you can see in the image, right, this organism made its way into the legs. Yes, and you see just moving. Cutaneous larva migrans, it is just migrating. Yes, one place to another place. Okay, all right. So that is the reason, even though how much ever we like to walk on the beach barefoot, but it is highly recommended to just cover our feet, at least with something, we should be covering it about. All right, it could be anything, but definitely not worth getting infested by these. Okay, all right. So that is all about the parasitic skin infections. I hope this was very interesting one. Not a lot of histopathological aspects, and lot of that classical derma thing which we are doing. No antibodies being formed. No antibodies, no reactions. No nothing. A very different perspective of the subject. Yes. All right. So I hope you had a good listen to it, and I hope I did justice to your time. Thank you so much for your listening.